So next speaker is Donn Colby. Donn's a research clinical physician at the USA Military HIV Research Program. He was formerly working with us at the Thai Red Cross AIDS Research Center, doing studies on HIV cure research and HIV acute infection. At the end of last year, he moved back to the USA, and we miss him terribly, but fortunately he continues to collaborate with us on HIV and STI studies. Thank you, Donn.
Okay, thank you for the introduction, and thank everybody who's stayed to the last end of the conference. So I'm going to talk a little bit about STI management, maybe not so much about management, but STIs in general. So a few different topics that I'll cover: epidemiology, antimicrobial resistance, PEP for STIs, and then maybe something called new STIs. First, epidemiology. So I think everybody knows that STIs worldwide are increasing, and there's a lot of them out there. So this shows by region, and if you look at East and Southeast Asia, there's more STIs in this region than anywhere else in the world, but probably just because there's more people in this region than anywhere else in the world. And if you add up all those numbers in the different continents, it comes out to somewhere about 380 or 400 million. So that really means that there's 1 million new STIs in the world every day of the year. So in my country, the United States, as well, actually in 2018, saw the highest number of STIs that they'd ever seen. It's just the numbers are going up. You can see all the different types of STIs that we see, my draw your attention down here is syphilis among newborns. So this is kind of something we thought didn't happen anymore, that you had mother-to-child transmission of syphilis, but we do, and I'll talk about that a little bit more later in the talk. And then this one is data from the US, and it just shows, I think, something that we all know is that young people are at higher risk for STIs than anyone else. So in this, the green is age over 25, and the purple color is less than 25, and it basically means that about half of all STIs are occurring in people between the ages of 15 and 25. So the next couple of slides, I'll show some data from our cohorts here in Bangkok. This is from the RV254 Search 10 cohort of acute infection at the Thai Red Cross AIDS Research Center. In that cohort, we identify people in acute HIV infection, so it's a new HIV diagnosis, and then we screen them for STIs before they start ART, and then we do once a year while they're on ART. And we find very high rates of STIs. So you can see at HIV diagnosis, chlamydia and gonorrhea are around 25 to 27%. And that goes down over time, but even as we follow for several years, we still see incidence rates of 10 or 15% in our HIV positive cohorts. And it's a similar story with syphilis. Syphilis at diagnosis of HIV is high, kind of 15 to 25%. It goes up and down a little bit every year. And then we see incidence every year, also about 10 per 100 person years. It's also about 10% per year for syphilis. Again, this is in HIV positive MSM. But if you look at MSM in many regions of the world, it's a very similar story. So in this map, the dark green color is a syphilis prevalence rates of above 5%. And you can see many regions reach that threshold. So where we are in Southeast Asia, and Thailand, and many other countries have syphilis rates above 5% for MSM. Same in South America and some European countries and North Africa as well. And if you look at female sex workers, it's the same. So in this one, the dark pink color is more than 5%, and just those same areas that have high prevalence rates of STIs for MSM also have high prevalence rates for female sex workers. So again, where we are, Southeast Asia, a little bit in Europe, not so much, but South America again. So I said I'd talk a little bit more about congenital syphilis, and I bring this up because this is actually now a priority for the WHO. So everybody knows what PMTCT is, right, from the HIV world. So now we have EMTCT. So that's elimination of mother-to-child transmission, but not of HIV, of syphilis. Because I showed you that in the United States, there's quite high rates of that happening, and that's true of many places in the world. So the WHO has actually set 2020 as a goal to reach not 90-90-90 like we have for HIV, but 95-95 for syphilis, for congenital syphilis. And that basically means that 95% of women should be tested for syphilis during the period they're pregnant, and then 95% of them that test positive should have treatment. And the goal is to get 70% of countries to that 95-95 level by 2020. But actually, if you look just a couple of years ago, 2017, only 6% of countries were there. So that goal probably will not be reached. Actually, there's 11 countries in the world that have already eliminated MTCT of syphilis. And actually, Thailand is one of those countries. Malaysia, also in our region here, is one of those countries. Most of those other countries you probably never heard of. They're small islands in the Caribbean, probably never had much syphilis to begin with. And then if you look down here at the chart, you can see the seroprevalence of syphilis in ANC, and they're quite low. In Africa is about 2%, but most other places are kind of 0.1 to 1%. And if you look at these numbers, these are actually very similar numbers to what we see for HIV. So in most countries, including most countries in Southeast Asia, the syphilis sort of rate in ANC, their general population, is sort of in the 0.3, 0.5%. So syphilis is very similar. So that first 95 was for testing. This shows that the percent of women in antenatal clinics in each region who have a syphilis test before they give birth. And actually, our region here, Southeast Asia, has the lowest rate in the world. I just told you that some countries have been very successful at achieving EMTCT already, including Thailand and Malaysia. But the issue is that there's other countries in the region that are doing quite poorly, and that sort of brings the average down. So in this chart, the darker the blue is the higher the percent of women in ANC clinics that have syphilis testing. So in our region, you can see, like I said, Thailand, Malaysia have very high rates, more than 95% testing, so they've reached that 95% goal. China is up there as well. But then we have some other countries like Indonesia and India with very big populations, but very, very low testing rates. So I'm going to move on from syphilis and talk about HPV. We don't really, usually in our HIV clinics, or in our conferences talk too much about HPV, but I think it's important because it's a sexually transmitted disease and it's a vaccine preventable disease as well. So we have the technology at our hands to eliminate HPV, or at least eliminate a lot of the harm from HPV in terms of cancer. So this slide shows data from Thailand, and we can see that Thailand actually has a very high rate of cervical cancer, one of the highest in the region. Now HPV can cause other cancers, not only cervical cancer, it can cause anal cancer in MSM, it can cause anal cancer in women as well, and it could also cause oropharyngeal cancer because HPV can be spread by oral sex. But if you look at the cancer rates from cancers that are caused by HPV, far and the highest is cervical cancer, and the others are much, much lower. This other chart may be difficult to see, but in this chart just shows the sort of morbidity and mortality from different types of cancer in Thailand, and third down the list is cervical cancer. So it's a very big cause of morbidity and mortality in Thailand. And if you look at other places in Southeast Asia, there's a lot of countries that have very, very similar rates, some even higher than in Thailand. But there's also some countries that do very well at decreasing the rates. Singapore and Vietnam, which are kind of both like opposite ends of the economic spectrum, but there's something that they're doing right there in terms of preventing cervical cancer. So as I mentioned, there's a vaccine for HPV, so cervical cancer is a vaccine-preventable disease. And the countries in green here are countries that have the HPV in their national vaccination programs. So in our region, there's not many countries that have it, but you can see that Thailand and Malaysia have that. Now, having them in the national programs doesn't necessarily mean that the national program pays for it or even subsidizes it, but at least it's a recommended vaccine. But even with that, in our region, the vaccine coverage rates for HPV are very low. So here we are in Southeast Asia. You don't see any bars there, and there's no bars because they said it was too low to even measure. They couldn't put a graph in because everything would be zero. So of course, I said there's some countries that are doing very good. If you look here, like Malaysia has more than 90% coverage of HPV vaccine for women. Young women at least, and that's because they do it in the schools. So almost everybody's in school, and so a girl goes to school, she gets an HPV vaccine. So it's very, very simple, and you get very, very high coverage rates. But right next door in Singapore, which is a very wealthy country, they have a very, very low rate. The other issue is that I think in most countries, the vaccine is indicated only for women because it's seen as a way to prevent cervical cancer. But of course, HPV is a contagious disease that can affect males as well as females. In the US, the CDC added an indication for HPV vaccine for males way back in 2011. But as far as I know, I don't think any countries in Asia are giving HPV vaccine to males. I can say that I think I have 2 boys, and I think that they were the first boys in the whole country of Vietnam to get the HPV vaccine in a public clinic, basically because I brought them in 2011 when the CDC came up with the recommendation and asked for it. And of course, the doctor said, no, I cannot give it to you because it's a cervical cancer vaccine. Why would you give it to boys? And even I showed him the whole printout from the CDC. Turns out the head of the clinic was also an HIV doctor who I knew very well, so I called him up on the phone. And he just went back another day when he was there, and we got the vaccine. Of course, I paid for it. It didn't cost the taxpayers of Vietnam any money. But you know, we gave it to my sons, and they're protected against HPV. Okay, next, touch briefly on antimicrobial resistance. So and when we talk about STIs, the STI that has the sort of the greatest impact from drug resistance is gonorrhea. So on this map shows different areas and different rates of gonorrhea resistance. So the blue is no gonorrhea resistance. So actually, here in Thailand, there's actually has not been any resistance for gonorrhea to ceftriaxone. That's the main thing we worry about is resistance to ceftriaxone for gonorrhea. So there's never been a case of that in Thailand. But the red and the orange are the places with the highest rates. And if you look at Thailand, on 3 sides, there's the countries with the highest rates of gonorrhea resistant to ceftriaxone in the world, in Myanmar, Vietnam, and China. So it's probably only a matter of time before it's going to come here to Thailand and other places in the region. So this shows that when the surveillance is done for gonorrhea in different places, what they found, and this is actually the data from the US, and you see about half of the gonorrhea isolates are susceptible to all the drugs, but that means half also have some sort of resistance. In terms of the resistance to specific drugs, the highest is to the fluoroquinolones we can see here, and then to the other drugs as well. And actually the resistance to ceftriaxone is quite low. It's just like a few percent, but that's what we worry about because that's our main treatment for gonorrhea right now. So there's actually surveillance for gonorrhea resistance to antibiotics in Thailand that's done on a regular basis. And this is just the most recent report that they have. And this is done, they take samples from men with symptoms of arthritis in 2 clinics in Bangkok. One is Bangkok Hospital, which is over near Saturn Road, and then the Siloam Community Clinic. And actually, the results, actually said, are pretty good. As I mentioned, there has not been any resistance to ceftriaxone. This is the graph for ceftriaxone. This is the level that resistance would be of concern, and everything, met the sensitivity was below that level. And that's true of almost all the drugs we've looked at, except for this one here is a ciprofloxacin. So I think we all know that in the past you could actually treat gonorrhea with fluoroquinolones like ciprofloxacin, maybe back in the 90s, but the resistance to ciprofloxacin and the fluoroquinolones developed a while ago, so we stopped using it, but the resistance is still there. But at least in Thailand, we don't have to worry about resistance to any other drugs at this time. Okay, next, PEP for STIs. So you might have heard about this before. So PEP, of course, means post-exposure prophylaxis. And one of the big studies that did PrEP for HIV, the IPERGAY study that was done in France and Canada, as part of that study, they also included a component of PEP for STIs, right? So that study, they did kind of PrEP for HIV and PEP for other STIs all at the same time with the same people. And it's a very simple regimen. You just take one pill of doxycycline, 100 milligrams, after you have sex, and it's supposed to be done within 24 to 72 hours after sex. Actually, what they showed is that it actually decreased the number of STIs that people got. So if you look at STIs altogether, the rates decreased by about half. For all STIs, but specifically chlamydia and syphilis went down by about 70%. Gonorrhea, there was no change at all in gonorrhea because gonorrhea is not susceptible to doxycycline, so that kind of makes sense. So it's kind of good news because as I've said and you've probably heard, STI rates are increasing in almost every population in almost every place of the world that we look at it. So if we have something like PEP for STIs, that might be a good thing and might be a way to help stop it from going up further and maybe reverse the increase in STI rates. But of course there's concerns about giving antibiotics out freely like that in terms of resistance in maybe some of the sexually transmitted infections or resistance to other bacteria and that people are exposed to if you're giving out antibiotics freely like that. So I don't think there's not been a consensus yet on whether this is a good thing or a bad thing. But I think in the near future we're going to see maybe some kind of implementation science type projects or demonstration projects trying this in the community and seeing if it works. So my last one is new STIs, and that's kind of a new STIs with quotation marks because they're really not that new. So one is Mycoplasma Genitalium. This is something like I never heard of like a few years ago, or you sort of heard of it and you think, well, what is it? Is it important? Do I need to know about this or not? But I think you do need to know about it because it's. I think in the past it was a little controversial. Is it a sexually transmitted infection or not? Does it cause symptoms or not? Or maybe it's just kind of like a normal flora and we don't need to worry about it. But I think there's been enough evidence now to show that it really is a sexually transmitted infection and that it really does cause symptoms in some people, although not all people. So it's a bacteria. It's actually the smallest bacteria we've ever discovered in the world. Maybe that's why it took a long time to discover it. It was just discovered in 1981. It doesn't have a cell wall, so that means when you do a gram stain, you cannot see it on a gram stain because you need the cell wall to keep the stain in the bacteria. It's also very, very difficult to culture, so you cannot culture it either. It's kind of like chlamydia in that regard. And also like chlamydia, most people who carry this bacteria do not have any symptoms. So most people are asymptomatic. But it does cause urethritis in males. So it's estimated that for non-gonococcal urethritis, about 10 to 20% are caused by mycoplasma. It can cause cervicitis and pelvic inflammatory disease in females. So to screen for it, there is a test. Is basically NAT-based testing that we can use because I said you can't see it on a stain and it cannot be cultured. but the recommendation is not to screen people who don't have symptoms. So I mean, we do routinely now, at least in our HIV clinics and some of our PrEP programs, we will screen people for gonorrhea, syphilis, chlamydia, even if they don't have any symptoms at all. But the recommendation is not to do that for this infection, because there's no evidence that screening and treating people who are asymptomatic would be any benefit at all. But there is evidence that at least if people have symptoms and have a test positive for mycoplasma, that treating it does help with the symptoms. So you can see the treatment. The treatment is antibiotics there. It's a little different than our other STIs. The course of azithromycin is longer for mycoplasma than it would be for chlamydia. So giving somebody 1 gram for azithro for chlamydia is not going to treat mycoplasma. You've got to treat it a little bit longer. And it's also recommended that if somebody is diagnosed and treated for mycoplasma, that we test their partners as well, or if the partner cannot come in and get tested, we can treat them, kind of partner treatment without testing, as we do for other STIs. And after treatment, it's recommended to follow up and test again after 2 to 3 weeks to test for cure. So I said new STIs, and some of these are not new diseases, but maybe new to think of as an STI. So hepatitis A is a sexually transmitted infection. That's not how most of it is transmitted. Most of it is transmitted, like we all learned in medical school, by fecal oral route, but it can be transmitted through sexual activity as well. So this is a paper that came from Taiwan in 2016. They had an outbreak of hepatitis A among HIV-positive MSM. And it seemed to be transmitted through sexual spread. In 2017, there was an outbreak in the Netherlands, and actually many countries in Europe, also of hepatitis A, and again seemed to be spread by sexual contact. How do we know it's spread by sexual contact and not by the normal route? Basically because it's very concentrated in these populations, and it's not getting out to the rest of the community. So unless all the MSM are eating together in one place and not going somewhere else, and not eating with their families, they're not getting it from food because nobody else in the community is getting it. And then in 2017, we actually had an outbreak of hepatitis A among our HIV-positive MSM cohort here in Bangkok. So we did the phylogenetics, and we can do the phylogenetics on the hepatitis A, and we can see that it was not related to any other hepatitis A outbreaks that had ever been in Thailand or the countries around Thailand that are transmitted by the normal route, which would be contaminated food or water. But actually, it was the virus the hepatitis A virus that we found here among the MSM in Bangkok was the exact same virus that caused the outbreak among MSM in Taiwan, and the exact same virus that caused at least some of the outbreaks of hepatitis A in Europe as well. So obviously there's this community of MSM that there's going around meeting each other, maybe on holiday or for work in different parts of the world, and transmitting hepatitis A through sexual contact, and it's not getting out into the community. Although we did see in Bangkok there was 2 cases of the exact same hepatitis A virus in children that came to Chulalongkorn Hospital. So the presumption was that probably the MSM had originally contacted it through sexual spread, and then somehow it got out maybe to their family or friends or neighbors through the normal routes of transmission. And then hepatitis C is also an STI. So like back a long time ago when I went to medical school, we said hepatitis C is transmitted the same way as HIV, the same way as hepatitis B. Can be through sexual spread or through drug use. But for hepatitis C, it seemed kind of different. It seemed like it was much more difficult to spread through sexual contact, and that most of the people that we saw with hepatitis C were intravenous drug users. But at least in the last kind of 10, 15 years, there's been quite a number of outbreaks of hepatitis C in MSM, and mostly HIV-positive MSM that are not drug users. So it really appears that the hepatitis C is mostly through sexual transmission. So this is a paper that came out a couple of years ago in Sexual Health that combined data from a lot of different studies and papers. All of these were cities in Western developed countries. I think there might be Tokyo in there as well, but every place else was Europe, United States, and Australia, and big cities. And they found a lot of hepatitis C. Interestingly enough, like almost all of them were HIV positive. So they really were not seeing hepatitis C in the HIV negative MSM. It was all the HIV positive MSM. And the other interesting thing is that in most places, none of them were injection drug users. In some places, they had a few injection drug users, but the vast majority of the MSM getting hepatitis C were not drug users, so the presumption is they're getting it from sexual contact. So this has also been described in Asia. This is a paper actually just came out last year that looked at this exact same phenomenon. So is acute hepatitis C infection in people with HIV in 3 cities in Asia, Hong Kong, Taipei, and Tokyo, and they'd all seen very similar outbreaks. And just like in Europe, almost all of the people who got hepatitis C were MSM. So here you can see 95, 98% were MSM, and almost none of them were injection drug users. They had 1 or 2% that were injection drug users. So again, the hepatitis C is being transmitted through sexual contact. Interestingly enough, they also did this paper this came from was the molecular epidemiology, so that's the phylogenetics. And they found actually in these three cities, they were completely separate epidemics. They were even different types of hepatitis C. It wasn't even the same type. One city had like type 1 place was like type 3, another place was like type 1B, another one was type 2. They were completely separate epidemics. And then we've seen the same thing here in our HIV positive cohorts in Bangkok. Before 2014, we never saw any acute hepatitis C or hepatitis C incident cases in our HIV-positive patients. And then from 2014 to 16, we started to see a few cases, and then 2017 and 18, it just kind of went through the roof, and we saw a lot more hepatitis C among the HIV-positive MSM. And then we looked at like what is what's this related to? So one was group sex. So again, this is sexually transmitted. Drug use, particularly methamphetamine. We can see there was, of this, there was like 39 cases, and only 2 of them were intravenous drug users. So that was not a significant factor. And then syphilis too. And maybe syphilis sort of helps transmission, or maybe syphilis is just a marker, another STI, and a marker of risky sexual behavior. And then in these hepatitis C cases from the HIV-positive MSM in Bangkok, we did the phylogenetics. This was, I think, 48 acute cases. And what we found is they were all, like the hepatitis C virus was almost exactly the same in 80% of them. So really what that means is we've had it's a very new epidemic with rapid spread within this community, because the virus is the same. The virus hasn't had time to evolve into a new virus. So that kind of confirms the chart I showed in the previous slide, that the transmission is new. It's really just the last few years wasn't happening, and it's happening in a very kind of tight network. And that's the end of the talk. Thank you.